two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checco from India.
Welcome to eCritCare Podcast. This is our episode number 89. And today I'm joined by my co-host, Dr. Jose Checco. So welcome, Dr. Checco.
Hi, Swapnil. Good evening.
Good evening. So how's things in India with this recent outbreak with Omicron?
It looks like it's peaking in most parts of the country. Hopefully, it will plateau off in the next couple of weeks. That's what we are hoping. The worst may be over, but still we have a large number of patients who come to the outpatient, and some of them do get admitted to hospital as well. Although I must say that severe illness with lung involvement appears to be quite rare with the Omicron wave.
Yeah, I guess that resonates with what we are seeing here in Australia as well. I think overall numbers are probably stabilizing now, and number of hospitalizations are slowly decreasing. So hopefully this modeling is correct, and in next couple of weeks, everybody will start seeing less number of cases in their hospitals and in ICUs. Now, today we have decided to discuss another interesting topic, which is a randomized controlled trial published in Lancet very recently. And thanks, Dr. Checco, for forwarding this paper. The trial is called as Michelle trial, which is basically evaluating the role of rivaroxaban as an extended thromboprophylaxis after the hospitalization in patients with COVID-19. Now, a little bit of context to this study, that we all know that thrombotic complications are quite common in patients with COVID-19, and prophylactic use of anticoagulants are recommended when patients are admitted to hospital. So often we see that we use either Clexane or heparin for DVT prophylaxis in most of the patients who are admitted to ICU or in hospital. Now, having said that, there is no consensus around the use of extended thromboprophylaxis beyond the hospital stay. If you look at some of the data registries, there has been a significant record of the venous thromboembolism ranging from about 1% to 2.5% in patients with COVID-19. One of the largest prospective registry data suggested that 4,906 patients with COVID-19, when they were discharged home, the incidence of primary endpoint, which is comprised of venous thromboembolism, arterial thromboembolism, and all-cause mortality, was roughly around 7.13%. And it was 46% lower in patients who were prescribed post-discharge prophylactic anticoagulation. So there is some signal in the registry data that if you prescribe patients with COVID-19 DVT prophylaxis after they get discharged from the hospital, there is some benefit. Having said that, there is no any randomized controlled trial on this topic available so far. But in non-COVID-19 patients, there is a previous trial called as Mariner trial, which evaluated rivaroxaban of 10 milligram or 7.5 milligram based on the creatinine clearance adjustment once a day versus placebo for 45 days after hospital discharge in 12,019 patients who were medically ill. Now, although this trial did not achieve superiority on primary endpoint of symptomatic or fatal venous thromboembolism, there was a statistically significant around 56% reduction in the relative risk of pre-specified outcome of isolated symptomatic venous thromboembolism, along with 27% relative risk reduction of symptomatic venous thromboembolism, along with all-cause death, and 28% relative risk reduction in major and fatal thromboembolic event. Another interesting finding in this trial, when the patients were prescribed extended DVT prophylaxis, there was no increased risk of major bleeding, which is always the worry when you prescribe any anticoagulation for extended duration. So the overall data in non-COVID-19 patients was quite interesting. And that's why I guess this trial decided to evaluate the role of extended DVT prophylaxis in patients who were discharged from hospital. There are obviously conflicting recommendations around the role of post-hospital discharge extended thromboprophylaxis in patients with COVID-19. So this trial hypothesized that in patients hospitalized with COVID-19, prophylaxis with rivaroxaban 10 milligram per day for 35 days after discharge would improve clinical outcomes, including major and fatal thromboembolic events. So, Dr. Jacko, can you please walk us through the methodology and the results of this Michelle trial?
Yes. As you mentioned, the study question was, in patients who are hospitalized with COVID-19, does prophylaxis with rivaroxaban 10 milligrams per day for 35 days after discharge improve clinical outcomes, including major and fatal thromboembolic events? So that was the study question. The study was conducted across 14 hospitals in Brazil. It was a 1-to-1 randomized controlled trial. Thromboprophylaxis with rivaroxaban 10 milligrams per day, or no anticoagulation were the study arms for 35 days post-discharge. It was an open-label study in permuted blocks of variable size using a central concealed web-based automated randomization system. The study included patients who were hospitalized with COVID-19 for at least 3 days. Patients who required ICU care were also included. And all these patients received standard thromboprophylaxis during the hospital stay with either unfractionated heparin, enoxaparin, or fondaparinux. The inclusion criteria was an increased risk of venous thromboembolism with an improved score of 2 to 3 and a D-dimer of more than 500 nanograms per mil, or an improved score of 4 or more regardless of the D-dimer level. So this was the inclusion criteria. The improved score, as you know, includes history of previous venous thromboembolism, known thrombophilic condition, lower limb paralysis, cancer, immobilization for 7 days or more, ICU admission, and age more than 60 years. They excluded patients with suspected or confirmed thrombotic event. They did not do a pre-study Doppler or CT angio to look at the likelihood of pre-study thrombosis. So the interventions were rivaroxaban, as we mentioned, in a dose of 10 milligrams per day for 35 days after discharge. The patients were followed up at day 7, either on the phone or at the clinic. And they were also followed up on day 35, which was at the clinic or at the hospital. A lower limb venous Doppler and CT pulmonary angiogram were carried out at this second follow-up at 35 days. The statistical analysis was based on a reduction in the composite primary outcome. The composite primary outcome included symptomatic or fatal venous thromboembolism, asymptomatic venous thromboembolism detected by bilateral lower limb venous Doppler ultrasound or CT pulmonary angiogram, symptomatic arterial thromboembolism, and cardiovascular death at day 35. So that was the composite primary outcome. So they assumed a reduction in the composite primary outcome from 15% to 5%, which is a relative risk reduction of 67% and an absolute risk reduction by 10%. For 80% power and a significance level of 0.05, they required 282 patients, and assuming a dropout rate of 10%, they increased the sample size to 320 patients. So they screened 997 patients, out of which 677 were excluded for various reasons, and 320 were randomized. 159 were analyzed from each group because there was one dropout from each group. The patients were well matched at baseline, rivaroxaban versus control. The mean age 57.8 versus 56.4. The median duration of hospitalization was 8 days in both the groups. ICU admission rates were 54% with rivaroxaban and 50% in the control group. And anticoagulation during hospital stay included 86% with enoxaparin and 14% with unfractionated heparin. So let's look at the outcomes. The primary composite outcome, which as I mentioned, included symptomatic or fatal venous thromboembolism, asymptomatic venous thromboembolism as diagnosed by Doppler or CT angio, and symptomatic arterial thromboembolism, including myocardial infarction, stroke, limb ischemia, or cardiovascular death. So these were the components. So the primary composite outcome occurred in 5 out of 159 patients in the rivaroxaban group compared to 15 out of 159 in the control group. So that was 3.14% versus 9.43 rivaroxaban versus control. So this was a relative risk of 0.33, confidence interval 0.13 to 0.9, the P of 0.02. So clearly it showed that the primary composite outcome was lower in patients treated with rivaroxaban. They also looked at each of the components of the primary outcome in detail. Symptomatic pulmonary embolism was 1 in the rivaroxaban arm, 2 in the control arm. Asymptomatic DVT on the duplex scan, 3 versus 1. Symptomatic DVT, 0 versus 3. Fatal pulmonary embolism occurred in 3 patients in the control arm compared to none in the rivaroxaban arm. And asymptomatic pulmonary embolism, as seen on the CT scan, occurred in 1 patient in the rivaroxaban arm compared to 4 patients in the control arm. The incidence of arterial thrombosis, arterial emboli were extremely low. There was only 1 patient with symptomatic arterial thrombosis and only 1 patient who suffered a cardiovascular death, both in the control group. So if you look at it, the individual components of the primary outcome were not statistically different between the 2 groups, although the composite was in fact in favor of rivaroxaban. They also looked at several secondary outcomes in various combinations. Symptomatic and fatal venous thromboembolism was 1 versus 8, rivaroxaban versus control. Symptomatic venous thromboembolism and all-cause mortality, 4 versus 9. The composite of symptomatic VTE, myocardial infarction, stroke, and cardiovascular death was 1 versus 9. They also looked at safety outcomes. The primary safety outcome was major bleeding. There was none in either group. The secondary safety outcomes were clinically relevant non-major bleeding, other types of bleeding, and a combination of major, clinically relevant, non-major bleeding, and other bleeding, none of which was different between the 2 groups. So essentially, the studies showed that the composite primary outcome of symptomatic of fatal venous thromboembolism, asymptomatic venous thromboembolism as diagnosed on Doppler or CT angio, and symptomatic arterial thromboembolism was lower, significantly so, in the rivaroxaban group compared to the control group, although the individual components of the composite outcome were not significantly different between the 2 groups. And it appeared to be a safe intervention with no increase in the risk of bleeding.
Thanks, Dr. Chakos. So I guess this trial is quite interesting for me. It tried to evaluate a question that has not been answered before with randomized controlled trials. So this is the first randomized controlled trial on this topic. And also at the moment, there is a lot of confusion about extended thromboprophylaxis in patients with COVID-19. So these trial results are definitely welcoming from that point of view. Having said that, there are a lot of limitations, and that's why the results of this trial need to be taken with a bit of pinch of salt. So first and foremost, this is an open label design, which has got a potential risk of bias, especially concerning the clinical event ascertainment. Now, even the way the statistical power was calculated was quite problematic, because one thing is they use the composite primary endpoint. The second thing is they aim for a very high relative risk reduction, almost 67% relative risk reduction in the primary outcome in order to achieve the power. And that's all, and with that too, with the 80% power. So I guess this study is definitely very underpowered to answer this question. And we shouldn't be jumping to any conclusion just based on these results of this trial yet. Now, the another potential limitation is there was no placebo in this trial. And authors claim that if they would have included placebo in this trial, that would have obviously made the trial not feasible. The good thing about the trial, though, they included CTPA. Now, the question is really the fatal pulmonary embolism on CTPA was observed in less than 5 patients in either control arm or in the intervention arm. So I guess really, does that matter to project every single patient for 35 days of anticoagulation? That's the key question. And even if you look at the first consort diagram in terms of number of patients who were excluded, almost 677 patients were excluded from this trial due to various exclusion criteria. So I guess overall, this trial is extremely underpowered, and probably drawing any conclusion at this stage becomes a little bit tricky. Now, as authors mentioned, there are so many other studies are in the pipeline at the moment, and hopefully those trials will tell us a bit more about the overall direction of this treatment. There is a study from Mexico enrolling 130 patients, which will evaluate the prophylactic and full dose heparin administration in hospital, followed by rivaroxaban 10 milligram per day versus no intervention. The second study is called a ZACH trial, which will include 150 patients who will be randomized to in-hospital enoxaparin or oral rivaroxaban 10 milligram per day, 15 milligram per day, or 20 milligram per day through discharge for 28 days. And in that trial, they are evaluating the primary outcome of death, mechanical ventilation, intubation, and transfer to ICU. Again, it's a composite endpoint for that trial. And I think the most awaited trial is called as Active 4C trial, which is the largest trial on this topic, which will include around 4,000 patients in USA to assess the effectiveness and safety of anticoagulants and antiplatelets, which include apixaban, aspirin, or placebo. And I guess the primary objective of that trial is to decrease the rate of myocardial infarction, stroke, arterial, and venous thrombosis and death within 30 days after the hospital discharge for moderate to severe COVID-19. And finally, there is another trial called as HEAL COVID, which is planning to enroll patients at hospital discharge after the first admission due to COVID-19. And in that trial, patient will be randomly assigned in a 3-group trial to apixaban, statin, or standard of care. And again, the primary efficacy outcome is hospital-free survival over 12 months. So there are various trials are coming out with the different endpoints, with the different strategies, and they're probably trying to address the same topic through the different lens. So I guess it might not be the complete answer, but I guess the Active 4C sounds to be probably the most important trial with large number of patients, including that trial will probably give us a better signal than Michelle trial. So that's my initial thoughts. What's your thoughts, Dr. Chakko?
Yes, Swapnil, as you rightly mentioned, the number of events overall was quite small. And in fact, the incidence of fatal pulmonary embolism was none with rivaroxaban, 3 in the control group, and one of which actually was based on clinical suspicion and echocardiographic findings alone. So it was 0 versus 2. And the third patient was not really confirmed on CT angio because it couldn't do it. The incidence of symptomatic pulmonary embolism as opposed to fatal pulmonary embolism was 1 versus 2. Again, very small numbers. So as you rightly mentioned, the sample size was not really large enough to come to really robust conclusions based on this study. And the other important thing to look at is the fragility index. When I looked at the fragility index of this study, if one of these patients from either group had a different outcome, the results of the composite primary outcome would have become non-significant. So that is also, again, suggestive of the fact that the level of significance is pretty low given the small sample size. And also, they did not look at pre-existing clots by either ultrasonography or CT. So that could be a limitation as well. You could argue that some of these patients may have had pre-existing clots which may not have been diagnosed. So overall, and of course, the study itself was heavily funded by the manufacturers as well. So that, again, adds to the conflict of interest, which, of course, the authors have declared.
Yeah, that's correct. I guess these are all very important limitations, and that's why jumping to any conclusion seems to be a bit premature at this stage. Authors do mention that looks like in Brazil, there is a large program of anticoagulation in COVID-19 going on. And as a part of that program, there are other few trials are in the pipeline as well. One is the CARE trial, which is enrolling at the moment 1,000 COVID-19 outpatients with moderate symptoms to either rivaroxaban 10 milligram versus placebo to reduce the need for hospitalization and mortality. So that trial is probably looking at preventative thromboprophylaxis as a preventative measure. And then there's another trial called as Coalizao Action Trial, which basically compared in-hospitalized patient with COVID-19 who had elevated D-dimer concentration. They tried therapeutic anticoagulation with rivaroxaban 20 milligram once a day, followed by rivaroxaban 20 milligram once a day for up to 30 days. And that trial actually importantly gave a signal that therapeutic anticoagulation is not beneficial and it can be actually harmful because it increases the risk of bleeding. So the overall program seems to be promising, and they have obviously produced some of the important results with the other trials. But based on this trial, as I said, at the moment, changing practices seems to be a bit premature for me. I guess we have to probably wait for the 4C and maybe perhaps results from REMAP kappa recovery, if they have a similar domain in that trial to address this anticoagulation or to address this extended thromboprophylaxis in patients with COVID-19. So I think probably I will not be changing my practices at this stage. What about you, Dr. Chakmo?
I agree with you, Swapnil. I don't think this can be called a practice-changing study by any means. We just have to wait for more firmer conclusions from larger studies before we come to any kind of major change in our clinical decision-making.
All the listeners, thanks for listening to our 89th episode. We'll be back with another episode in week's time. Till then, stay safe and have a good time.
Thanks, Swapnil. Thanks, everyone, for tuning in. See you next time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.